My case presentation is over a patient I saw in the ER experiencing an inferior STEMI. My patient was a 58-year-old male with sudden onset substernal chest pressure radiating to his left arm and jaw. He rated the pain 9 out of 10 and described it as crushing. It started about 45 minutes prior to his arrival to the emergency department. He had associated diaphoresis, nausea, and dyspnea. This patient had no known allergies and had a history of smoking a pack of cigarettes a day for the past 35 years. Reports only social alcohol use, denied any drug use. His past medical history was hypertension, type 2 diabetes, hyperlipidemia, and a family history of MI. For his review of systems, he was positive for diaphoresis, positive for chest pressure, and positive for nausea. His vitals were as follows: a blood pressure of 168/94, heart rate of 112, respiration rate of 22, and oxygen saturation of 92% on room air. He was ill-appearing, diaphoretic, tachycardic, his lung sounds were clear, and he didn't have any focal neurodeficits. The patient's EKG showed ST elevation in 3 separate leads, indicating an inferior STEMI. A CBC, CMP, and troponin were sent, but the patient ended up being in the cath lab before those resulted, and his chest x-rays showed no acute findings. My differential diagnoses included a STEMI, and then unstable angina, aortic dissection, PE, and then GERD or esophageal spasm. Immediate management in the emergency department included 325 milligrams of aspirin, sublingual nitroglycerin as needed, placed him on oxygen, and got IV access. A heparin bolus was started. Administering heparin to STEMI patients in the ER can increase the rate of coronary artery revascularization, and he got morphine as needed as well for pain. The reperfusion strategy would be to activate code STEMI and get the patient to the cath lab. In patients with STEMI presenting with less than 12 hours after symptom onset, PCI should be performed with activation of less than or equal to 90 minutes to improve survival. Dispo was to cath lab, then to CCU.